Yeah.
that is a concern in some areas, not all, but that does not negate all of the concerns regarding the medications.
Correct. Yeah. So is the short course, that's a good compromise?
Well, I think
That's what we've already done.
we've already been covering that. So the question now is, so have we already been covering the CBTI? I don't
Yes,
understand.
yes.
So what are we supposed to be, what are we changing?
Behind you. So we are trying to address a concern by a provider that CBTI is not readily available and trying to outline, if you can't do CBTI, what could you do? We could also say, we don't want to change our guideline. The evidence is really that CBTI needs to be done. However, you can get it. So I think our options would be make no change, accept the staff recommendation, or send it back for more work and let us know what you want us to do.
Okay, there's our options. Adrian has a significantly furrowed brow.
No, I mean, I'm trying to, like, I think I normally don't go against like staff recommendation or whatever, but I mean,
Absolutely go.
I am like, I'm kind of thinking just leave the guideline the way that it's at. I mean, if the intention was that we are going to cover insomnia and we're going to cover insomnia treated to kind of the gold standard, then that's like CBTI. I mean, I do think that it's unfortunate and there's a real access issue, but because there's an access issue to CBTI doesn't mean that I think we should be covering sedative hypnotic medications in this space. Because the risks there are real. So
yeah, the testimony from Dr. Henderson was that some of the medicines other than Ambien had less side effects, but if you don't agree with that.
Well, and so I'm sorry, I did not include the DERB report because it was just published. It was not in your packet. But the bottom line was that they appear to be not really significantly better in their estimation.
Which means they just have more side effects.
And didn't you use it at a lower dose?
That was the doxepin.
Yeah. Oh,
Yeah,
okay.
That's a long, old
Yeah.
DTA, right?
Yeah, and if you use it, the dose for insomnia is a strange dose. There is an almost equivalent dose if you cut a pill in half that would be really inexpensive and would be available through the mental health card.
It's a capsule.
Oh, well, I guess you could take 10 milligrams instead of 6 milligrams.
10 milligrams. I mean, we used to do it. You just prescribe 10 milligrams.
Yeah.
It's
Or you could-
commonly done.
You could take the capsule, break it.
So Adrian, are you ready to make a?
I guess my next question, I guess, does our derm colleagues or like pharmacy and therapeutics, do they like this? What's their preference? Like, do they want an adjustment to this guideline note, or like, do they think there's a problem here? I guess would be my question.
I think everybody thinks there's a problem with access to mental health of all kinds.
But that's not our purview to fix today.
Yeah, it's not.
But specifically, do they want changes around policies related to access to sedative hypnotic
I
medications?
don't think so, and I think in the pharmacy side, this would actually make it hard because they would have to document, they'd have to look for more documentation rather than just, are there codes for behavioral health? Or is there a documentation that a CBTI referral was made or whatever? So I think making no change would be reasonable. And then
Again, we already covered CBTI and we already covered 2 weeks worth of the
30 days.
medications.
Yeah. And it doesn't matter whether the CBTI can be telehealth or in person. So,
Correct.
Right.
and then there were some language barriers too, because there's very, very few Spanish speaking options for.
There's a lot more than there used to be.
That's great.
Again, can't solve everything today.
Yeah. I was just trying to recall the discussion from yeah.
Let's focus on this little document in front of us. I would entertain a motion of any kind.
This is Mary. I would move to make no change at this time.
I'll second that.
Sarah seconds. And remember, we can always, it doesn't have to pass, and then we can do another motion. So so y'all know, it's fine to be controversial. So, should we vote on this piece? Because we voted on the last piece. So let's vote on this piece, please.
Absolutely. Antoinette,
I approve the motion.
Mary, Mary
Approve.
Beth,
Approve.
Adrian,
Approve.
Sarah,
Approve.
Chris,
Approve.
Holly Joe.
Yes, please.
And Lucy, you have your hand up. Oh, Lucy's here. Awesome. Let me make you sorry, I stopped looking. And
You've made
Lucy, I'm making you a panelist. It'll take just a moment.
Yes, I second. Yay, Lucy.
She's never been.
Here I am. I vote aye. Lucy, were you here for the last discussion, or would you like to vote, or you're just arriving?
I was listening as a visitor. I will vote aye.
Excellent. And Dr. Holly Joe Hodges, did you vote?
I said yes, please.
Thank you so much. I was just so excited about Lucy here. Lucy, so a motion passes. Thank you so much.
Hey, great. Welcome, Lucy.
Okay, let's go ahead and do voice sitting. Funny time.
So our next topic is surgical treatments for obstructive sleep apnea. This was brought to you as a coverage guidance in June. The coverage guidance itself was approved by HERC. However, the application of the coverage guidance to the prioritized list was sent back for additional work. The specific questions that were raised by VUBES and HERC members, we had said you needed an adequate trial of CPAP. There was a request to define adequate. What does this mean? Is it 1 month, 12 weeks, etc.? We need to have a follow-up with a sleep specialist or respiratory therapist to address any physical issues with the CPAP setup, etc. There was also a question about whether mandibular advancement devices should be required or tried before surgery. There was a request to work with our pharmacy and therapeutic staff regarding rare medications such as tirzepatide, which have been approved by the FDA for sleep apnea, where they would fall into the decision matrix for surgery. There was a question about requiring CPAP for persons with disabilities who may not be able to use CPAP without an assistant or caregiver helping them. And then there was a question about the evidence supporting the use of drug-induced sleep endoscopy. This had been a recommendation by staff to move that to coverage to help with surgical planning. There was a request to look at the evidence of whether it changed surgical management. So staff looked into all of those questions. A lot of this came from the underlying studies of what was defined in CPAP for adequacy of CPAP trials or for other insurance definitions. So what is generally considered a quote unquote adequate CPAP trial is Aetna says 1 month. Regents says at least 4 hours a night for 5 nights or more a week. And then we had also said if you couldn't tolerate CPAP, lack of CPAP ability to tolerate CPAP is defined as inability to use CPAP more than 4 hours a night for 5 nights per week, or unwillingness to use it. In other words, e.g. patient returns the CPAP system. Regents, same thing, unable to tolerate for more than 4 hours a night for 5 nights a week, or refusal to use CPAP. And then lack of adequate benefit from CPAP would be an AHI greater than 15 or 20, depending on the insurer, despite CPAP usage. We talked to pharmacy and therapeutic staff about tirzepatide. And the P&T staff noted that all studies to date on the effectiveness of tirzepatide excluded patients who were going down the surgery pathway. And so it appears to be an alternative, not a step therapy for surgery. For mandibular advancement devices, none of the trials included mandibular devices. And the American Academy of Sleep Medicine does not list it as a treatment option prior to surgery. And we received some ad hoc expert input that these aren't appropriate in many cases because based on anatomy, etc. They're also quite hard. You have to find a person who's willing to make a custom molded one, and these can be quite expensive. And our experts didn't recommend having, they should be available as an option, which we do, we currently cover them, but they shouldn't be in the decision pathway for surgery. And then in terms of the drug-induced sleep endoscopy or DISE effectiveness, we actually reviewed this a year ago. In March 2024, we included two recent systematic reviews, actually 3 recent systematic reviews, and an expert consensus. These reviews showed that the DISE did not change surgical management or surgical decision-making. So
In adults.
in adults, yes, we cover it in children, and it does make a difference in children, particularly those children who may have varied anatomy. But so in summary, for CPAP criteria, staff is recommending that we have a adequate trial defined as 1 month or 4 weeks. That unable to tolerate CPAP should be defined as unable to use CPAP for at least 4 hours per night for 5 nights or more per week. And that reasonable attempts have been made to address any medical, mechanical, or psychological problems associated with the CPAP. Or the lack of availability of an appropriate trained caregiver for patients who are unable to use CPAP without assistance. And then inadequate response to CPAP should be defined as having an AHI for greater than 15 despite CPAP usage. So those definitions will be slotted in to our guideline. Medications appears they don't actually have, they shouldn't be included in the surgical decision algorithm. DISE, based on our recent evidence review, it does affect surgical outcomes in children, but not adults. So staff have removed the previous recommendation to add coverage for DISE. We're recommending continued non-coverage of DISE in adults. Mandibular advancement devices, based on a lack of inclusion in the trials, as well as our expert input, we don't recommend including as modality that needs to be tried prior to surgery. And then there was one additional request, I believe actually it was from you, Holly Jo, asking for some clarification of wording regarding CPAP for children. And that's the current guideline. It appears to require tonsillectomy before coverage of CPAP, which is not our intent. It was our intent that that surgery works better, it should be considered that a child can have a tonsillectomy if they're
They don't have to have a tonsillectomy before they can try CPAP.
exactly.
So,
So-
thank you.
The recommended guideline, no changes. So guideline note 27, treatment of sleep apnea. We would strike the sentence saying that we don't cover surgery for adults. We would add surgical procedures are covered. For UPPP, it's kind of the same. You have to have an AHI 4 of 15 or greater, etc. And then documentation of one or more of the following regarding CPAP. You have an inadequate response defined as an AHI 4 of 15 or greater, despite using CPAP for a minimum of 4 hours, 5 nights or more a week. Or you cannot tolerate CPAP or other appropriate non-invasive non-pharmacologic treatments after a minimum trial of 4 weeks. An inability to tolerate CPAP is you can't use it for at least 4 hours a night, 5 nights a week, and you've made reasonable attempts to look at medical, mechanical, or psychological issues, or the lack of an appropriately trained caregiver for patients who are unable to use it without assistance. And then it's seeing very similar wording for tonsillectomy alone. And then for children, it would say undergone surgery and have documented residual symptoms, or they're not candidates to surgery or preferred try medical treatment alone.
Let me go back up, please.
Can you really speak up if you're facing?
Yeah, it's really hard to do these things. Okay, so first off, why are we changing the definition? Why do we require 3 months why do we use the CMS Medicare definition for continuation? Of you have to have been compliant 70%, more than 4 hours, 70% of the time, in 30 days of a 3-month period. In 3 months. So, because when we give people CPAP, it's a trial of 3 months. So I'm just wondering why we,
So the CPAP coverage subsequent to the initial 12 weeks. So basically, continued CPAP coverage is defined at least 4 hours a night and 70% of the nights in a consecutive 30-day period. So we could modify and use
I would
that.
like the language to be consistent. I understand that we're basically asking for the same thing, but when you change the language to 4 weeks, 30 days, it just changes it feels different. It feels like we've changed things. We really haven't.
So that would, so we're saying at least 4 hours a night for 5 nights a week. So that would
I would
be
prefer that you
from the
say
night at
70.
70% of the night.
With the, yeah, just make the terminology the same, and CMS terminology is 70%. Mary, do I have that right? It's right, it just, that's
That is my
Same.
understanding. Agree.
70%. And the reports come to us as a percentage of compliance of days, so it would be impossible to be able to judge 5 days out of every 7. Honestly, looking at the compliance reports, as I recall. I could probably pull one up today.
Yeah, I just pulled up the language and you're right. It's at least for CMS 4 hours, 70% of nights within a 30-day period, the 30-day period.
Okay, so wherever we had previously said a minimum of 4 hours for 5 or more nights per week, it would now say at least 4 hours per night, 70% of the nights for a consecutive 30-day period.
Thank you. That would be,
Repeat that one more time.
that would be consistent.
Here, let me. Yeah.
Yeah, and Mary, I'm right, we have no way on those compliance reports to be able to tell if it's 5 out of 7 days, 5 days in a row, 2 out of, 2 days on, 2 days off, 2 days on, 2 days off.
I'm trying to think, I am not sure about that. That's a good question. I look at the overall number, right? But you're right. I'm not
Yeah, I
positive.
think all we're given is, set that amount of days, 19 of 30 days equals this percent or something.
I
We
think
don't get that much detail, and there's no way we're gonna get it.
Yeah.
That's too much work. And I'm not sure I care. 5 out of 7 days, which 7 days?
I think we're talking a lot about the same thing, but
Yes.
if we want to keep consistent.
Consistent language, and when you have to review this, there's no way to be able to determine that other language.
So you have here. So instead of at least 4 hours.
Right, instead of this, we do this, right? At least 4 hours per night. Another nice for me.
You gotta get rid of at least 4 hours, that first one.
Okay. And we'll make that change.
So what this says is a patient has an inadequate response to continuous positive airway pressure, CPAP therapy defined as an AHI 4 of 15 or greater, despite using CPAP for at least 4 hours per night and 70% of the nights during a consecutive 30-day period. And any time that reappears for at least 4 hours per night for 5 nights or more a week, it would be the highlighted wording instead.
Right, so where it says.
So there's
trial
4 places it
instead of
appears,
4 hour,
it would change.
4 weeks, it'll be, all those things. It's the same all the way through. That will be immensely helpful.
Okay.
We're saying the same thing, it's just, this is much easier to
Sure.
determine based off
And
the
it's
reports
more
we get
consistent within the guidelines.
and within CMS overall.
And then it appears twice for tonsillectomy as well.
Okay, so for tonsillectomy, and this is in adults, right?
This is an adult.
This is in adults. Same stuff. Okay,
So we change there using C, so.
yeah, we'll change that.
Hey Ariel, this is Marcus. I just have some information to add about this one, if that'd be helpful.
Of course.
So we got that definition of CPAP intolerance from the hypoglossal nerve stimulators. That's the definition used in that. So that's why we aligned it in that way. But I agree totally with the comments that it makes sense to align it with the compliance reports, but just some insight into why we propose that in our coverage guidance.
That's helpful. Thank you.
Mhm.
And then, yeah, when you get those, keep going down. I want to see this last part, please.
You called that minimum trial flows. Anything you wanted me to do there?
Doesn't that also need to, a
No.
minimum trial of
You
4
can't
weeks?
tolerate after 30, basically. You want me to say consecutive 30-day period here instead of trial of 4 weeks?
So, well,
We
because
define-
it needs, because
we define-
oh,
But
but
it's
it still
still
needs,
it has to be 30 days.
Yeah,
Minimum trial.
so minimum trial 4 weeks, but it still needs to say, it has to be an adequate trial. They can't
Yes.
just have the thing sitting
This
on.
is indented. It's like, if this is defined as.
Oh, and then we,
Here.
and then it.
Yeah,
defines it here.
But if we're gonna say 4 weeks, we should say 30 days.
Got it. Is defined as either, so the inability to use, so it has to be an adequate trial. They can't just put it on the bedside. Like some of my family members. And then, all other surgeries are included in line only for children who meet this criteria below. So we probably need a space before 4, just to make sure they understand we're moving to a different topic. Thank you.
Hi, it's Mary. I don't think this is probably here nor there, but I'm going back and looking at the CMS criteria for hypoglossal nerve stimulators. And if I'm getting a little dizzy from going between screens, but I think we did it right. We can double check that because I agree with staying consistent with CMS. But if I'm interpreting this correctly, because I'm like, oh, should it be the same? But anyway, I think it's okay. I think we did it right.
I don't think we're talking about hypoglossal nerve stimulators right now.
I agree. I was thinking about the comment that was made earlier, which I appreciate from Marcus, I believe, about and consistency with CMS. So I agree. I kind of went off on a tangent on that. And I was thinking, should these be similar? But yeah, so that's kind of a tangent, but I think we are looking at it correctly.
Okay, good. 2, are not candidate for surgery or prefer to try medical treatment alone. Okay.
So basically, if you have surgery and you still have symptoms, or you can't have surgery, you don't want surgery for kids.
Okay.
Do we remove this and here?
No, that's for D.
And B, okay, thank you.
Okay. Oh, actually, we don't have ands for like A, B, and C. So
Yeah.
We should probably get rid of that.
Well, then we'll go back to the top. Do we say all be below?
For children 18 or younger,
And I think they're actually ors.
No, they're different things,
So
so
they don't, so we don't.
they're
need any.
appropriate, you can use an intranasal steroids.
Well, they're ors then. Or. Adrenaline.
I think we should just leave it alone, stand alone, and then we can get rid of the and that's now hanging in nowhere.
Okay. All right. Does that all make sense to everybody? Thoughts, comments?
So, yes, just one thing on DICE, that we and Marcus and I have had some conversations with Dr. Derek Lamb, who is one of the experts on these 2 OSA topics, who I think felt pretty strongly that DICE should be at surgeon discretion. That it wasn't a particularly expensive thing, and that he felt that in some cases when it wasn't clear what the surgical approach should be, that he personally found DICE to be quite useful in surgical planning. And that he felt that it at times had been a situation where he thought surgery might be warranted, but he wasn't sure. and after doing DICE, felt like it wasn't warranted. So it saved some surgeries.
Yeah, and
So
Dr.
just-
Lamb has shared all of that
Yeah,
sentiment
so
with
just-
us.
Since you guys weren't at that
Yeah.
committee meeting, I think that's the only other thing to say.
And just as a follow-up, one of my staff sent me a compliance report and it indeed just gives you 18 days versus 7 days of more than 4 or less than 4 hours per day and a percentage.
Okay, so. Yeah. No, and I think we're gonna be internally consistent. I think it's essentially the same thing.
It is.
It's just different.
Yeah, it's just that there's no way to find out which days. those are.
Exactly, I think.
So that's good.
I think it's an improvement.
Yeah.
So we have,
We-
multiple places where it
we-
says
we'll look up
4
which
weeks,
dice
we're
it
changing it to 30 days. When it says a minimum of 4 hours for 5 more nights a week, it'll say at least 4 hours per night on 70% of the nights for consecutive 30-day period.
Do we have a CPT code for DICE?
If you, and you can put it in.
That would be great. Could you tell me what it is?
I can grab it, yeah.
I have that it's 42975, I think.
What were you trying?
Look up on the fee schedule. And I don't think it's inconsequential.
And it involves anesthesia, so there's some risk.
General anesthesia is not a benign procedure. Ever. Other thoughts,
Yeah, it's-
concerns?
Typically, it's not general anesthesia. It would be moderate sedation to mimic, or even light sedation to mimic sleep is the technique for that test.
But our evidence review previously showed that in general, in the studies, DICE doesn't change surgical management.
Yeah, so.
I have fee schedule 63371.
I'm sorry, was that the price?
Correct.
633.71.
$633.
Yeah, I'm looking at y'all. Other thoughts, concerns, questions? Anybody ready to make a motion?
I'll make a motion that we accept this.
Approve the staff recommendation as amended.
Approve the staff recommendation as amended.
Thank you, Lucy.
I second this as amended, Chris.
Thank you, Chris. Let's run a roll call, please.
Absolutely. One moment, please. Antoinette?
I think she just put in the chat that she had to drop for a
Oh,
different
I'm
meeting.
so sorry.
Stephanie, that's a 9:30 timestamp for your records.
Appreciate you. Thank you.
So do you want to start new discussion?
Mary?
Passing the table nerve
Approve.
typical tuberculosis.
Adrian?
But we need to keep.
Approve.
Lucy?
Yes, approve.
Sarah?
Approve.
Chris?
Approve.
And Holly Joe Hodges.
Yeah, thank you.
That's 6 for a quorum and it passes. Thank you.
Great. We are actually a little ahead of schedule, and I forgot to mention at the beginning of the meeting that we're having a friendly agenda change. Chris Superling, who is the podiatrist who's been helping us with the BP podiatry, couldn't come later in the meeting, and our public member is already here. So we were suggesting when Dr. Superling gets here around 10:15, we'll convert over to the podiatry topics. I was hoping to have a break around 10. We can kind of get him situated. we can do the podiatry, but for now, for the next 25 minutes or so, I think we can get some of the new discussion topics, if that's okay with everyone. The first on our list for new discussion was basivertebral nerve ablation, and I know we had a person who is going to come virtually. Daphne or Michelle, is that person here?
I don't believe so. Let me do another check. Oh, Dr. Baker is here, yes.
Okay, so we can go ahead and talk about basivertebral nerve ablation. And then if we get done with this topic before 10, we'll move on. And we do have one person who is going to give us public testimony on this. So basivertebral nerve ablation is a procedure to treat back pain by affecting the sensory nerves as they leave the vertebral body. And it is a method for treating low back pain when patients have a very specific change seen on their MRI in the lumbar lumbosacral area. We reviewed this most recently in 2021. That review included the Intercept and SMART trials, which were two industry-funded RCTs, so with a total of 198 patients in the treatment arm and 133 patients in the standard care or sham arm. At that point, because of the two studies with a small number of patients and only short-term, I believe at that point there were just a couple of week follow-up outcomes, we decided to add this to our what is now excluded guideline note 2 because of inadequate evidence of effectiveness. This came back to us at the request of Boston Scientific, stating that they now have longer term outcome data. So for the evidence, the literature search was limited to 2021 or later. There was a systematic review published in 2023 that included 11 studies. There was one systematic review, 4 publications out of the SMART trial, 3 publications out of the Intercept trial, a cohort study of 48 patients, and 1 narrative review. So essentially this adds MACADIG, which is that cohort study of 28 patients, to the previously reviewed trials, although they now have longer follow-up periods for those trials. According to the authors of this systematic review, there is moderate quality evidence supporting the effectiveness of basivertebral nerve ablation for patients who had the specific MRI findings. However, when looking at the underlying trials, which is still just the SMART and Intercept trials, as well as 1 additional cohort study, there are still small sample sizes, as well as the continued methodologic concern. So the RCTs allowed crossover. So after 6 to 12 months, a patient who was in the control or sham arm crossed over to the procedure arm. So long-term effectiveness is really difficult to distinguish at that point because both groups had the, in many cases, had the intervention. And then there was another systematic review published in 2021. Again, it was the Intercept and SMART trials. They also included 4 case series. Then another evidence review published in 2021 noted there were systematic reviews of 7 studies. These were basically included all in the first systematic review that I mentioned, except for there were 2 additional observational cohort studies, 1 with 16 patients, 1 with 28 patients. The manufacturer submitted an extensive literature list, and the ones that were, several of them I excerpted above. There were a couple of other follow-up studies, mostly looking at the long-term impacts, again, of the trials that allowed crossover. So getting to the bottom of their 66 submitted publications. Expert guidelines, their SAD in 2022, there was a best practice guideline for treatment of tuberogenic pain. They recommended the basivertebral nerve ablation for patients who have failed 6 months of conservative therapy. And they note that it's a promising treatment. In the International Society for the Advancement of Spine Surgery policy statement from 2022, they stated that basicutaneous nerve ablation supported by basic and clinical evidence, including a systematic review, a level 1 sham controlled RCT, a second level 1 RCT comparing with conservative management, and 3 single group prospective studies. And then they noted that outcome data at more than 5 years of a single BVNA procedure suggests the durability of treatment effect. And then the North American Spine Society recommend basicutaneous nerve ablation for skeletal mature patients who have failed adequate non-surgical management and have the specific motor changes on their MRI. So Kaiser felt that there was insufficient data in the published medical literature to support use. United Healthcare considers it experimental. Aetna considers it experimental, as does Cigna. Anthem has, they do cover it for basically what the International Spine Societies would be, and Pacific Source and Providence and Nurity and Medicare have similar coverage. So in summary, since the last review in 2022, the literature that has been published consists of 2 cohort studies of 56 and 31 patients, 1 case series of 118 patients, and 1 claims analysis. I didn't go into that in detail. There was a claims analysis study that used a proprietary database, and we were not able to determine what the underlying claims data was. And the systematic review was published that included 2 additional cohort series with a total of 44 patients. All the newer studies have significant limitations, including a lack of comparison group, unclear follow-up timeframe, use of an administrative database with a non-verifiable underlying data. So those were the limitations of the additional published literature. Additionally, long-term follow-up of the previously published RCTs continue to show improvements in pain and function, but they allowed crossover between 3 and 12 months, making comparison between the groups difficult in the longer term. Since our 2022 review, which at that point no private payer was covering it, additional private payers and Medicaid have added coverage. However, Aetna, United Healthcare, Kaiser, and Cigna continue to consider it to be experimental. So definitely varied coverage in the private and Medicare world. Expert guidelines continue to recommend it as a treatment for qualified patients. There has been additional harms that have been published. It was associated with an increased risk of vertebral compression fractures up to 10%, mainly in patients with osteoporosis. And there have been follow-up studies published as the 2022 reviews that show durability of the improvements, but the new cohort and case series do not show any robust new effectiveness data. There's methodologic limitations in the published literature. And we briefly spoke with our CEBP colleagues about possibly doing a coverage guidance, but just for your information, only 1 of the additional studies would meet the usual basic inclusion criteria. But because it has a proprietary data set which did not report the underlying claims data sources, it would also be excluded. So essentially, they wouldn't be including any of the additional literature. So based on the continued lack of robust data of effectiveness, HERC staff continue to recommend non-coverage, and the recommendation would be to simply change the late date of last review and our excluded services guideline E2 to August 2025. Before we have our 3 minutes of public testimony from our person requesting testimony time, is there any questions for me, clarifying questions, etc.? Otherwise, I see your hand up, Mary.
Hi, thanks. Just one question. I don't see that it's listed in an up-to-date yet. And then also, I cannot find that it has full FDA approval. I find the device has 510(k) FDA approval, but maybe I'm not seeing it on there. So those were my 2 questions. Well, I guess 1 question.
That might be a good question for the person who's giving us public testimony, who is from the manufacturer. I don't know that off the top of my head about the FDA approval. I would assume if Medicare is covering it, it has some type of FDA
Yeah.
approval.
If it's 510K, that's called FDA cleared,
Okay,
but those terms get
okay.
used loosely.
So we will make sure that we can ask that question for our testifier when he's done with his testimony. Just keep a pin in that, Mary.
And just to clarify, I think that 510K is pre-market clearance only. So there might be a piece of that I don't understand, but yeah, just having them clarify that would be really helpful.
That's another clarifying question. So when I'm looking, because you said Medicare coverage, and I guess I'm looking at the payer policies, the only thing I'm seeing is a Noridian Medicare LDC 2024. So I mean, is that just an MA, a singular MA plan is covering it? Or when you say Medicare coverage is?
I'm sorry. So our local Medicare has a local coverage determination.
Okay.
So we have some
Not
Medicare
in-
coverage in our area.
Okay.
Thank you for the clarification.
And what Medicaid plans are covering this? Because I saw public comment and you just mentioned it, that some Medicaid plans are covering it, but I didn't see any specifics.
I wouldn't be able to tell you off the top of my head. I didn't document that. Other questions? Otherwise, we have someone who wants to give public testimony. Daphne, if you could do our usual introduction.
Absolutely. Dr. Angra, you still have your hand up. Was there something else you wanted to say? Thank you so much. Dr. Baker, I'll promote you to, let me start over. Dr. Baker, in a moment, I will push the button that'll allow you to talk. But before I do that, I'd like to say a couple things about public testimony. This topic might be sensitive for some. As a reminder, HERC is a policymaking body and can't make decisions about coverage for individuals. Any policymaking decisions about that made today will go into effect at a future date. This discussion actually may be intensely personal for some, but in this forum, we tend to discuss subjects that seem clinical and maybe impersonal, and not every person's experience will fit into the picture that the clinical evidence shows. Please be aware that our commission's business is to make the best possible decisions for the general population using HERC's methodology and processes to determine the importance of services. So today we'll have 3 minutes for testimony. A progress bar will show how much time is remaining. And then after your allotted time ends, if you will remain in the meeting in case members have questions for you. It would be great if you could start your testimony by stating your name and any potential conflicts of interest you have regarding this topic. Dr. Baker, you have the floor. You'll have to unmute yourself.
Hi, good morning, and I appreciate the ability to speak before the committee today. My name is Ray Baker, and I'm a Chief Medical Officer of Boston Scientific. So that is a conflict of interest, I think. And I want to try to hit a few high points from the presentation earlier. I think one of the things that it's important to realize is that low back pain is a very costly problem in our society, and a lot of the problem with the cost is we haven't been able to differentiate various sources of pain. This procedure breaks that mold by having an identifiable source of back pain that is the vertebrae that we treat specifically. Only 1 in 6 low back pain patients have that condition, so we're trying to treat a very specific condition. Moving on from that, I think that the committee report said a number of times that we only had short-term evidence and short-term comparative evidence. And I would quote that the SPART study was a sham-controlled trial. As a sham-controlled trial, it took us 4 years to enroll to find 225 patients who would be willing to have a 1 in 3 chance of having nothing done to them, be placed under a general anesthetic, have a pencil-sized trocar placed into their back, and wait a year before they were able to cross over. So while it's easy for health technology assessment to say, you needed to have 2 or 3 year comparative follow-up, I would ask the committee to ask themselves, how many of you would undergo a sham procedure and wait 2 to 3 years before you were able to find out whether you would actually receive the attended treatment and be willing to cross over? So I really think within the limits of what we were able to do, we performed a very good sham control trial. We showed superiority over sham in the per protocol treatment arm, which is, as the FDA noted, the most appropriate arm for this study. I would also say is contrary to other treatments that are out there for low back pain, this is a one and done procedure, meaning that we do not have to repeat this as you would other low back pain procedures. We do one single procedure, so the cost effectiveness is quite high. With respect to the Intercept study, which is the second RCT, it's the only study that we're aware of in the low back pain space to ever stop early for superiority. We reached all of our primary and secondary outcomes at 6 months. By IRB convention, we had to notify patients that we had new data, that we had achieved our primary and secondary endpoints. At that point, we were forced to cross over. Instead of getting credit for stopping early for superiority, which is incredibly difficult in the low back pain space, we're instead discounted for not having longer term outcomes. So I would indulge that we do have 5.3 outcomes, 5.3 year outcomes with the Intercept procedure after a single procedure, showing a 60% decrease in opioids in 5.3 years, an 81% decrease in lumbar spine injections, and a 68% decrease in radiofrequency ablation. I think what's important to otherwise note is many of these patients, they don't have another treatment for vertebrogenic pain. There is no other treatment for vertebrogenic pain. So many of these patients will go on to fusion surgery. And that is a far more costly, far more destructive procedure. This procedure, the BVNA, does not include an implant. It's an outpatient.
Dr. Baker, could you wrap up your testimony for a time?
Thank you. I was just looking at the bar, and on my bar, it kind of froze, so I appreciate the update. So thank you. And it is 510K cleared, by the way, which is approval from the FDA to market the device. Thank you very, very much for your time.
Thank you. So Mary, did that answer your question about FDA? It's a FDA cleared, not approved.
But cleared for marketing.
That makes sense. And that's consistent with what I found. Thank you so much.
Any other thoughts, questions for our speaker? If not, thank you very much, Dr. Baker. Appreciate it.
Thank you.
All right. So the question before us.
Well, we can move on. So
I think we should do these one at a time.
Okay.
They're all very different.
Okay. So do you want to vote on this one?
And the recommendation in front of us is
continued non-coverage, just updating the entry.
So did y'all hear that? The recommendation is to continue no coverage based on the current review. Anybody thoughts?
I make a motion to accept that.
Thank you, Lucy.
And I second.
And Mary seconds. Roll call, please.
Thank you. Mary?
Approve.
Adrian?
Abstain for the moment.
Adrian abstained.
Abstain for the moment.
Okay, thank you so much. Lucy?
Yes.
Sarah?
Yes.
Chris?
No.
Colleague Joe?
Yes.
Adrian, how are you feeling now?
Can I ask Dr. Baker a question? Are we allowed to go back?
I don't know.
Yeah,
Is he
one moment. He's still
is he
here.
still
Let
here?
me take care of this.
I thought everything's good.
There you go.
Opportunity. Okay, Dr. Baker, we do have a quick question for you, please.
Yes.
So could you provide, I guess, and this other groups on the HERC or BBBS can also provide. So can you tell me a little bit about what a 510 clearance means in terms of medical device approval? And then specifically, I guess, so I'm a pharmacist, and so the parallel that I'm drawing in my head is a drug that has been approved through a fast track designation, a breakthrough therapy designation, and then there is an expectation that there is going to be further post-marketing surveillance to validate. And I guess my question is whether a 510 approval, if that's a comparable, similar but different, but whether that's a comparable analogy. And then if that is a comparable analogy, what is the current plan, I guess, for that post-marketing surveillance data?
So it's a really good question. The FDA typically takes two pathways to allow a device to get marketed. One is called the PMA pathway or pre-market approval. The second is called the 510K pathway. There are other pathways, as you suggested, fast track, breakthrough, etc. But those are clearly different. Now, the FDA can issue either a PMA or a 510K to allow a device to get marketed with or without post-market surveillance or post-market studies. In the case of the Intercept procedure, I was actually at the hearing when we were given 510K approval, which is full approval to market the device without any conditions. There were no post-market approval studies mandated. There was no need for anything post-market. This was, fully cleared by the FDA to be marketed as is. The difference between a PMA and a 510K gets to be a little technical. I'm happy to discuss it for the committee if you'd like it, but it's one and the same in terms of an ability to market a device. 510K is a substantial equivalence pathway, where PMA is a de novo pathway, but both require essentially the same rigorous FDA review. I hope that helps, but I'm happy to follow up with secondary comments.
So does that mean from a 510K, you go on and get full approval at some later date after something happens?
No, it is full approval. It's just two pathways to get through the FDA essentially, but both the pathways end at the same point. So there is no ability to go back to the FDA. This is not like an interim approval or nothing like that. In fact, a lot of devices that are probably before this committee are 510K approved. It's a standard pathway for clearance through the FDA. But no, it's full ability to market. There are no conditions. There are no secondary follow-up studies. It's not limited or anything like that.
Okay, thank you very much. And Mary, you just dropped off, but I'm going to come back to you in a minute. Go ahead, Val.
Yeah, so the 510K pathway is a predicate prior device pathway. So it is the pathway where the manufacturer says, look, FDA, you've already approved this other thing or these other things. Like your leads are sort of like those leads. Your implant is sort of like that implant. And because you've already approved those things, we'd like you to approve this that is being used in a newer way.
But a similar like,
yeah,
but
so
slightly different.
So 510K has been criticized because of not always putting those components together in the same way that the device is actually put together and generating new evidence for that specific device.
Got it. Okay.
Yeah, the general test is that there's substantial equivalence between the device in question and a predicate device, but there's some concerns about the use of predicate devices and just the pathway in general for medical devices broadly.
Not specific to this device, but just in general.
In general.
Yeah. So just general, sharing
Super.
general.
Got it. Mary.
Sorry, so I'm not an FDA expert by any means. So if it's 510K, the company, the manufacturer is still paying a fee to the FDA for evaluation of the device. I believe that's right. Correct me if I'm not right. And then my second question, which is more for our OHA team, does Medicaid cover devices that do not have full FDA approval?
What we're saying is that this 510K is a full FDA approval. It's just one of two pathways to approval for devices.
Okay. And so even though it's still being studied by the FDA, then it's considered a full FDA and they're still paying a fee for the study. It's still a full FDA approval. Is that right?
There's no more study. It's just approved.
Yeah, my understanding is that it's a final outcome. That determination is a final outcome, subject to, like Dr. Baker said, if the FDA puts post-approval surveillance requirements on the product, then that is an option. But in this case, he noted that they did not, so that the clearance in general would be considered a final outcome.
Okay. All right. Thank you very much. I think we're going to wrap this up because all of this has been for you. I just remembered, I'm like,
Really for me.
why are you talking about this?
I think I am still, I mean,
You're welcome
I
to.
think I'm
Can she-
still an
can she-
abstention. Like I am still an abstention. Like, and I apologize for that.
Then we'll,
So with that, then the motion would not carry, because there would not be votes.
Because we're missing-
sufficient for a quorum,
we're missing a quorum
so
until 11:30. So we can come back to this, or we can just send it like this.
send it to her, I think.
We're not missing a quorum. We just didn't have enough votes.
No, we don't.
If
The
Adrian
vote doesn't count
abstains.
if there are not 6 votes.
Right.
And so under public meeting law, encourage votes when possible. And if it's a no, it's a no.
So that's fine.
No, I can go.
Jason, Mary has her hand up again. I don't know.
All right. I just have one other question for the expert from Boston Scientific. Is there any ongoing litigation?
Mary would like to, I really think we need to move on.
Okay.
Because
Yes.
we've already voted and we're
I'll
waiting
vote
for
to approve
Adrian.
the staff recommendation. I'll
Okay,
vote to
so
approve.
we're just gonna move on. I'm sorry.
And I'll vote to approve the staff recommendation. We can move
And
on.
Adrian has changed her vote from an abstention to
Yes.
yes.
We got
5-1.
So it's 5-1.
So motion carries.
All right, thank you.
All right, it is 10 o'clock. I would propose a 10-minute break.
Yes, please.
Our podiatry expert apologizes, he's running a little late. We'll probably just do that discussion around 10:30.
But when we come back, we'll start with
about.
anterior tibial tuberoplasty.
Yeah, that's pretty straightforward.
My favorite. All right,
Just you President Blank.
everybody online, if you'll come back. If you'll come back online, I need my gavel, clearly.
Oh,
I have to gavel these people today.
I like the gavel. I'm big on the gavel.
No, right?
You can just do this.
Oh, I was just banging on it. Thank you, I love the presentation. Okay, we're having a little bit of rowdiness in the room, so I have my gavel now, in case I need to use it.
Right.
All right,
The
so.
The next topic is going to
Go
be
for it.
anterior tibial tuberculoplasty, and I just said that completely wrong.
TTO.
This has been a kind of a long-standing question from OHSU Orthopedics, and it was brought to us by our own Dr. Hodges because of OHSU requesting to use this code. So we have this code is not covered because it was used for the maquette procedure, which is not a currently done procedure. However, working with OHSU, it appears that this actually is also used for the Elmsley-Trellat procedure, the Fulkerson procedure, and the Rue-Goldthwait procedure, which are evidence-based, as much as most orthopedic things are evidence-based, basically systematic reviews of level 3 and 4 studies. Private payers cover this for these other indications. I was able to consult with Dr. Jacqueline Brady, who is an orthopedic surgeon at OHSU, and this is one of the procedures she does. She was able to explain that they use this for things other than the maquette procedure. And therefore, staff recommendation is to add these to the joint deformity line and remove the entry in our guideline, our excluded guideline 2, to allow the surgeons to use the code for appropriate procedures.
Mary.
I think this is the right decision. I've talked with a couple orthos over the last few years because of the exclusion issue. And I'm not even going to try to quote them, but when they went through the process of this procedure and the associated services and explained it, it completely made sense at the time. So I agree and support this decision.
That was my experience talking to Dr. Brady. I couldn't explain exactly what the nuances of it all, but
Yeah, I'm happy, just fix it, I don't care, I'm tired of this. I have been having this conversation with the same person since 2021. So, whatever you guys decide, I am happy with.
Mary, do you have another question, or is your hand just still up? Okay, great. So what's our desire? Do you want to vote on each of these?
Yes, we already have it, so I would entertain any kind of a motion.
It's
Motion to approve.
I'll second.
Was that Lucy? Yeah, Lucy moved to approve as recommended. Mary seconded. Please run the roll call.
Wonderful. Mary Beth?
Approve.
Thank you. Adrian?
Approve.
Lucy?
Approve.
Thank you. Sarah?
Approve.
Chris?
Approve.
Holly Jo Hodges?
Approve.
Wonderful. Motion passes.
Great. So now we can move on to BioFire Spotfire. This is a proprietary PCR testing platform. So it's basically a machine, and it can run, depending on how it's set up, one of two tests. One is viral and bacterial causes of sore throat. The other is viral and bacterial causes of upper respiratory infection, and they test for multiple different agents. This was brought to us by the manufacturer. So this test has a PLA code. Just to remind you all, PLA codes are proprietary laboratory analysis. When they are given to a test, they must use that test rather than the more generic codes. We cover multiple CPT codes that are for various PCR tests for various infectious agents that could cause a sore throat or a URI. There was clinical evaluation of the BioFire Spotfire test published by Chan in 2024. And they found that it essentially was in concordance with the other laboratory tests that are sort of more commonly, standardly out there. And the FDA approved this in 2024. The cost information, what I could find on the internet was that it costs approximately $125 to $602 per test. Single test agents for COVID or influenza are typically $25 to $50 a test. Other respiratory panels, for example, the Quest respiratory panel is listed as costing $910 to $1,565. Currently covered panel tests on our fee schedule are $152 to $291. So in summary, based on the FDA evaluation and a single independent study, the BioFire Spotfire system appears to be accurate to detect multiple viruses and bacteria to help identify the cause of pharyngitis and/or upper respiratory infection. We cover similar tests that use CPT codes and not PLA codes. It's got similar, the cost of this test is similar to the currently covered tests. And so the staff recommendation is to add those 2 PLA codes to the diagnostic procedures file. Questions? Discussion? Mary?
Hi, I'm looking back at my notes. We've had this really going around because we have 2 pediatricians, and I'm just asking this as a question. So one of their concerns is they're seeing this widespread, particularly in certain facilities. And what they're saying is based on the child's presentation that they just needed an RSV swab. And so was this medically necessary? And then the other issue, which I feel like the charge we're receiving is very different than what, well, maybe I'm looking at this wrong. So it was at the higher, yeah, it was pretty impressive compared to the standard panel. So I guess the two questions I have, well, I feel like it's reasonable to add to the fee schedule with the caveat, is it, it's a proprietary company. It's a private equity company that produces this, which is, it is what it is. That's a lot of things now. But is there substantial benefit of this swab over standard swabs? I don't know the answer to that. And then the concern with the fee schedule, because the pediatricians who work with do not feel it adds significant benefit in the vast majority of cases over standard testing. So I don't know if anyone can speak to that.
Based on the extremely limited studies out there, it appears to be equivalent to a standard test. I don't think it offers any benefit over the other panel. It seems to just be a variation of a different flavor of ice cream.
Well, and that's my question, and I don't want to punish facilities because, like, my background is an ER doc, right? Like, I don't I don't go choose the swabs. I grab a swab out of the drawer, and that's the one I use, right? And so, but there's, for some reason, certain facilities switch to this, and that's what they have. And I don't want to be punitive about it, obviously, if this is what the docs have and are working with. But it's just not clear to me if it's adding any benefit over the test we already have. And then the fee seems pretty significant. I think they buy their own machine, if I'm not mistaken.
Yeah, I think there's a upfront cost. You have to buy the machine, and then you use the machine. So there's obviously, just like any other machine that you have in your practice, once you have it, you're going to want to use it. And that's also available. You don't have to send the swab to a central lab.
Yeah, which is nice. And then where you go with that, right? And are we going to get a new machine and a different device and a different swab for every panel, right? And so like what is the ultimate situation? And so it's just not clear to me if there's any perverse incentives with this. And I don't know. I'm just asking that question. And is it adding anything over standard testing? That said, I'm fine with just getting this on the fee schedule because it's a very high end, and I don't think it's any different than the other swabs, but I'd be curious of others' thoughts on this too.
Is this for outpatient testing only, or is this also for use when it's on our fee schedule? Is it also for use in emergency rooms or inpatient or OBS inpatients?
We would be agnostic as to setting.
Okay. The panel test that they do, I think, tests for 15 different pathogens. which in the outpatient setting can be considered excessive, although under certain circumstances, especially for hospitalized or acutely ill patients, the number of pathogens that's being tested for may increase, and this may be appropriate.
Yeah, the current, like looking at the current codes, like CPT 87632 is 6 to 11 targets. 87633 is 12 to 25 targets.
Mm-hmm.
And then we have single tests, a lot of various. So it's within the range of 87633. Which we pay $291 for 87633. I think we have to set, the fee schedule sets it at a % of Medicare, so I don't know if we have input on the fee schedule for this.
This is Chris. I'm just wondering, does this open the door for requests for review for all the PLA codes? Because I remember that was pretty extensive. If there's other equivalents, like could that just be a very large body of work?
Yeah, so what we have decided in consultation with you and HERC is that we will not routinely review PLA codes because there are hundreds and hundreds and hundreds of them. We did a search for the most commonly used, most of which were actually like COVID testing codes, and we went through those and added some to coverage. And then we will review them on request or when OHA sees a sudden surge in use, and we will look at that code. Does that make sense?
Yeah, I'm just thinking of your scope and just how many like of these private businesses will start submitting requests, and I just wanted to have some limitations or just review because that could be
Just a
overwhelming.
comment about PLA codes.
Please.
CPT codes for specific tests are insufficient. There are a lot of non-specific CPT codes, and unlike drugs and many other procedures, the capacity to encompass all lab testing in CPT codes is insufficient. And so PLA codes are an acceptable alternative. So it would be equivalent to reviewing a CPT code. Sorry if that was excessively.
No, that's helpful. Thank you for the
Okay.
context.
Yeah.
Bigger buckets. Thank you.
Mm-hmm. So if it's on the fee schedule, that means it's covered, or that just means it lands somewhere in the decision hierarchy?
It would be covered if it was billed.
Mm-hmm. I mean, I think short of getting into the business of like technical assessment and test evaluation, if this is considered to be equivalent to other tests that we currently cover, I would be in favor of supporting putting this on the fee schedule.
I would agree with that. It still fits our definition of medically appropriate and effectiveness. So it's still, even with the way we're changing how we're making decisions, it's still consistent if it's in the same range.
Agree. This is Mary. I agree with that. And getting it on the fee schedule, I think will be helpful.
So I'll make a motion to approve placing this on the fee schedule.
So that would be approving staff recommendation.
Yeah, just to be clear, HERC does not control the fee schedule. That's our fee-for-service Medicaid program. Many of the CCOs reference that, but our decision is about the prioritized list, which often drives those decisions about the fee schedule. So it's a slight technical difference. And in this case, we're recommending it for the diagnostic file, and that's where we're just advising the Medicaid fee-for-service program on how to deal with the code. So
thanks for the clarification.
Yeah.
Motion to accept the staff recommendation. How about that?
Thank you, Lucy.
I'd second.
And Chris is seconded. Thank you so much. We'll go ahead and roll call.
Thank you.
Got
Mary Beth,
Approve.
it.
Adrian,
Approve.
Lucy.
Let's see. He's like, oh, he's coming. He's coming first. Okay. Are you to me?
No,
Lucy?
I'm at Lucy.
Oh, I said approve. Am I on
Sorry,
mute?
I didn't hear you.
Okay.
We can hear you.
Sarah,
Approve.
Chris,
Approve.
Holly Joe.
Approve, thank you.
Motion carries. Thank you.
All right, our next topic is intraspinal spacers for treatment of lumbar stenosis, and I am going to hand things over to Heidi.
All right. So just try to get this a little bit bigger here. So lumbar spinal stenosis.
This is page 289 on the meeting materials, if you're following.
Thanks. So the coverage question around whether should spinal spacers be covered for treatment of lumbar spinal stenosis. This question came to us from a CCO medical director. And so a review in background, the condition lumbar spinal stenosis is a condition that results in narrowing of the spinal canal, and that can cause other conditions which result in a variety of symptoms and can lead to progressive difficulties with activities of daily living. So interspinous spacers are one of the potential ways that you can decompress some of that compression that's happening from a lumbar spinal issue, and has been requested for us to review whether or not this is an alternative that we should cover for this condition. So previous HERC reviews, there was one in 2016, and at that point in time, there was no evidence of benefit for these devices as compared with traditional decompression. And then there was another review again in 2021, and the updated evidence review in the survey of payer policies at that time also found no evidence of recommendation to change the recommendation to not cover those spinous spacers at that time. So in our current review, we also reviewed some other payer policies, and they were currently were not any updated coverage guidance or any updated coverages of other policies than in this current review. I'm trying to make sure that I'm going with what's showing on the screen here. So this is just a review of what we've done previously. So we did another evidence review, and I updated what had been what I could find since the last review in 2021. So again, 2016 review, and then 2021 another review. So there were a couple studies that have been since published, and the goal of this first one was a meta-analysis of RCTs, looking at the goal to investigate whether the interspinous spacers were better performance for lumbar spinal stenosis when compared to the traditional decompressive surgery. And in this meta-analysis, there were inclusion of 8 studies, 852 individuals, and it was a direct comparison of the interspinal spacers to the decompression. It did show that in some of the studies there was a shorter operation time, and they did look at things like whether the dura, so these are complication issues, like whether the dura was violated during procedures, whether that was a safer issue. And then in some of the studies, there were some superior components, which you can see there. Then it was the interspinous spacer thought to be inferior was the rate of reoperation compared with traditional decompression. And then in some of the variables that were looked at, there were thought to be no difference. And those were things around length of stay, spinous process fractures, disc height decrease, some additional symptomatic things like pain scores for legs and back, as well as disability index and claudication severity. And those are some of the things I referenced earlier at the beginning that caused some challenges to daily living. So the authors in this concluded that both the interspinous spacers and the decompression were acceptable strategies for treating lumbar spinal stenosis, but recommended further, more well-designed studies that had a longer follow-up. But there was nothing else beyond that that we found as new evidence that had been published since the last review in 2021. There was one link submitted with the question, but we were not able to track down, despite my best attempts multiple times to track down the actual link and what they were referencing. There wasn't a title or anything like that. We also looked at the expert guidelines. Many of these had not been updated since the last 2021 recommendation, so I included them there for your reference. But certainly we did not have updates there. So this first one is from the North American Spine Society. We previously included that. If you can go down to the next page. And then there was a NICE also included in 2010, and this was included in the both prior reviews. And there was nothing additional from any updated evidence-based guidelines for practice since then. Other evidence policies that we reviewed, I looked at quite a few to see if there were any updates. All of these groups for other payers recommended non-coverage due to considering this still to be experimental or investigational, so not a covered benefit. I did also pool the Medicare Policy 2025 on their coverage determination. There wasn't a national policy for that, and it was thought that the evidence, current evidence as reported in this 2025 review, did not support the safety and efficacy of this. So in our staff summary, there was no expert input on this review. So our staff summary, we did not recommend coverage for this, given that there wasn't a substantially more evidence since the last time we reviewed, and it is considered in many cases to still be experimental and not necessarily, yeah, so I think the coverage is on the recommendation, staff recommendation is on the next page. Yep. We do not recommend adding coverage for interspinous or interlaminar process spacer devices for this condition based on the updated evidence review that we did previously. This is my first time presenting, so please, Jason or Ariel, let me know if I need to present anything else for this.
Heidi, this is Mary, and I was just going to text you that was a great job presenting and summary, so thank you. And I move to approve the staff recommendation.
Thanks.
I'll second that.
All right, any discussion?
Not a discussion, but I'm just curious, Heidi, when you went through, did you notice any additional harms?
So in one of the primary meta-analysis was really what was published since the last time. There were really, I mean, they compared where they thought it was superior, where they thought it was inferior. And I think the main thing that I saw in because I then also looked at several of these studies just to get my head around some of what they were finding. So there really, I think, was a higher reoperation rate. So I think that was kind of one of the big things. A lot of these other more symptomatic things were no difference, but I think the risk of having to go back again was really one of the bigger differences. So,
thank you.
And are we talking about updating? We're not talking about, somebody said somewhere about updating guideline note 173, which
I'm
no
sorry,
longer exists.
Yeah, there's a mistake in the
Got it,
material.
okay.
We apologize.
No worries.
Still lists the guideline at 173, but it will be excluded guideline.
It'll be
E2.
E2. Got it. Thank you. My staff is watching.
Apologize for that. Sorry,
Good job.
I slipped through all of our
No worries.
editing.
No worries. Okay, so other than that editing change, are we good to go ahead and vote? All right, great. Roll call please.
Mary Beth,
Approve.
Adrian,
Approve.
Lucy,
Approve.
Sarah,
Approve.
Chris,
Approve.
and Holly Jo.
Approved.
Motion passes. Thank you.
All right, I just want to note that Dr. Superling unfortunately hasn't arrived yet, so we're going to continue on with our new discussion items. Our next topic is blood-based tests for colon cancer screening. This came to us from a CCO medical director. So these are a blood test, and what the lab attempts to do is to isolate DNA with certain mutations that might indicate that there is a colon cancer.
That's page 294. Thank you.
There are two current tests that are FDA approved. I'm sorry, there's several that are FDA approved. We previously reviewed one called SEP9 in 2017 as part of a coverage guidance process, and that was placed on excluded services guideline E1. We last looked at colon cancer in 2021 when the USPSTF updated their colon cancer screening recommendations. The change that came out of that was lowering coverage of colon cancer screening in general to age 45. The USPSTF continued to recommend multiple modalities, including stool testing, FlexSig, colonoscopy, CT colonography, fecal DNA, and a blood test called epiprocolon. But essentially they were saying whatever people are willing to do. And currently we do cover multiple screening modalities for colon cancer. We cover FIT testing, FlexSig, and colonoscopy. That's in our preventive services guideline note 106. We do not cover the fecal hemoglobin test because of lack of that it's costs a lot more than other equally effective tests. And then the one HCPCS code for a blood-based biomarker for SEP9 is an excluded services guideline E2. This is going to be a little bit of a different presentation. Our evidence and expert guidelines and payer policies are in a separate document that should have been in your packet. Just to kind of orient you, because of legislative decisions, we have to have 2 evidence vendors. So we were lucky enough to have RTI International, which is it's similar to our CEBP evidence group. They're a similar group in North Carolina. And this was their first project with us, and they did a review of blood-based tests for colon cancer screening that you should have gotten a completely kind of like a little mini coverage guidance, very abbreviated, that they did for us. They note that there are 2 FDA approved blood-based screening tests, ColoHealth and Shield, but other tests are available for clinical use as laboratory developed tests that do not require FDA approval. The studies of blood-based screening tests have only reported accuracy, so sensitivity and specificity. No reports of harms in any of the currently, no harms were actually included in any of the current publications. They had concerns about test accuracy because of study design flaws, which mainly were in selection and spectrum bias, which can lead to an overestimation of test performance. These tests have somewhere between 66 to 83% sensitivity, specificity more in the 60 to 90% range, depending on the test. When compared with FIT, epiprocolon has been compared with FIT and Shield has. They both found that they were not inferior. So they work about as well as FIT testing. And just as an additional note, just like FIT testing, if it is positive, it is not a diagnostic test. You need to have a full colonoscopy as a true diagnostic test. There are the National Comprehensive Cancer Network, NCCN, and the American Gastroenterology Association have published updated guidelines that recommend using these tests only when a patient is unwilling to have any other modality of colon cancer screening. Medicare does cover this for patients with about a $1,500 reimbursement. No private payer is currently covering it. So they looked at their evidence review included 13 studies overall. Again, they were all sort of accuracy or comparing to FIT. I'm happy to go into detail about any of those studies if you want more specifics. And just a note, other guidelines, such as the American College of Physicians, recommend against this. So based on our RTI evidence review, my summary for you would be that the current literature on blood-based screening tests for colorectal cancer is limited. It contains no studies examining the impact of these tests on patient-important outcomes, such as reduction in colon cancer incidence or mortality. There are many other screening tests that have been shown in, for example, the USPSTF review to decrease incidence and mortality. sorry, this is morality, that's a typo, it's mortality. These include the tests that we currently cover, such as colonoscopy, FlexSig, and FIT testing. And no private payers currently covering these blood tests. This type of testing may increase a patient's willingness to undergo screening. However, the test is relatively high cost and you would still need to do a colonoscopy as the definitive test. The performance is similar to FIT, which we currently cover and is much less costly. HERC staff recommend continuing non-coverage of blood-based colon cancer screening tests due to the experimental nature of these tests and the relatively high cost compared to other equally or more efficacious screening modalities. If you agree with the staff recommendation, or the staff summary, the staff recommendation would be to update our current excluded services guideline E1 entry. And it would, so we have these modalities kind of all lumped together. We actually do now cover screening CT colonography and with a very specific guideline entry. So we would need to, that was never stricken, apologize. So we would have one entry for FIT DNA, which is Cologuard and chromoscopy. And then we would have a separate entry for the G03827 code, which would be blood-based colorectal cancer screening tests with insufficient evidence for use in population screening. And then for our guideline note 106, which is our preventive services guideline, we would change the code that says now SEP9 would just say blood-based colorectal cancer screening tests, so kind of clarifying some wording in that test. Questions for me? And also, if you have any feedback about the RTI product, that we are just beginning our working relationship with them, so any feedback that we can work with them on would be welcome.
I'd love to hear from Lucy. Thoughts? I can see your brain turning.
I'm chewing on it. I agree with the blood-based tests that the data is not there yet, but rapidly emerging, and would state for the record that I hope these tests become proven eventually, because the promise of blood-based cancer screening is huge. So I do agree with that piece. My understanding of the Cologuard test, as it is a stool test, not blood-based, is that its performance has been better proven, and it has been better established as an option for colon cancer screening in average risk individuals.
Yeah, so we've reviewed that somewhat recently.
Yeah.
It is about 600 times the cost of a FIT test and has about the same performance. So we have elected not to cover, and just as an FYI, OHSU did a big decision matrix for OHSU, and they specifically don't cover it for the same reasons. They feel it's the FIT is equivalent and much less costly.
Thank you. Other thoughts, questions?
And I'm sure, Lucy, that we will be seeing this technology again.
Over and over and over again. So just summarize for us what we're gonna look at.
We are not covering blood-based screening tests. There'll be some changes to excluded services guideline E1, which is basically our these tests work but not as well, or is similar to other covered tests. There's no benefit to them. Yeah.
Got it. All right, I'd entertain a motion of any kind.
I would move
Do
to
I-
accept the staff
I'll second.
recommendations. Thanks, Mary.
All right, Lucy made the motion and Mary seconded. Daphne, go ahead, please.
Thank you. Mary Beth,
Approve.
Adrian,
Approve.
Lucy,
Approve.
Sarah,
Approved.
Chris,
Approve.
and Holly Joe.
Yes.
Motion passes. Thank you.
Great. Well, we are still awaiting Dr. Superling.
You know,
He had sent me an email. He thought he'd be here at 10:30.
that's what we thought too.
Yeah, we should probably just go ahead then, I guess.
Yeah, we can work on ENT, which is actually how our agenda
Yeah.
is currently set up.
Great.
So the first ENT topic is basically a rather quick update on tympanostomy tubes, PE tubes. These are the little tubes that go in ears for people with recurrent and inner ear infections. We talked about this at our June meeting. There was a staff recommendation to combine the two guidelines, one for recurrent acute otitis, the other for chronic otitis. For the BUP 1127 change, members felt that
Page
this actually was
317.
members felt this was a very useful change and requested staff draft a proposal of that guideline merge that could be effective to 10/1/25. So that's why this is coming back to you. So the current, most of what you're seeing here is what you saw at the June meeting. There's just a couple of differences. They're effective 10/1/2025. There would be a combination of current guideline note 29 and 51 with the same wording that you saw with the BUP changes, except for we would have lines instead of code groupings, and there would have to be a few of the reversals of what we've been doing. So it would be on lines and not covered or not covered, those types of wording. And these changes went out to the CCO medical directors for input. They agreed with the changes. So it would essentially be what you saw at the June meeting, but there would be a version effective 10/1/25. And then there would be the previous recommendation, which was to create a new code group for PE tubes. There would be you actually didn't actually approve that, so it has to come back for formal approval. So all of the codes that would be put into that new code grouping, and then there would be a guideline attached to that code grouping that's essentially what you with a combination of guideline note 29 and 51 with that kind of simplification. Questions? Input?
Mary, does that make sense? I'm counting on you to glance
Yes,
through the.
always a little peek into Ariel's brain, which is always fun, right?
True that. All right, if there's no more questions or concerns, I would entertain a motion.
This is Mary. I move to approve.
Thank you.
Second.
Second from Lucy, and we'll roll call for votes, please.
Mary Beth,
Approve.
Adrian,
Approve.
Lucy,
Approve.
Sarah,
Approved.
Chris,
Approve.
and Holly Joe.
Approved.
Motion passes. Thank you.
That was
Just this.
just that.
Got it. Okay, so let's go ahead and drop back.
All right, so I would propose that we jump ahead. Just for the record, Dr. Chris Superling has joined us, who is the podiatrist who has been graciously helping HERC staff work through the BUP podiatry changes. We also have a member of the public here to testify.
Hi.
Okay, so we have multiple
Page 343.
multiple podiatry topics that are on the table. So we are moving, this is all the benefit update project. So these are all changes being proposed for 2027 with the benefit update project. We have some just general podiatry topics. Then we're going to talk about bunions and hammer toes, plantar fasciitis, plantar neuromas, and what am I? And orthotics.
And apologies, the general podiatry, I think we'll start with that, is 354.
And just for our guests that are here, Dr. Sufling, thank you for coming. Dr. Sufling is really here for questions. So if you have anything for him, you need any clarifications, he is here for you. And then I believe, ma'am, you wanted to talk about bunions. So once we get to that topic, I'll kind of go through the general, recommendations, then you'll be invited up to give testimony. And then if we would ask that you at least stay in the room for people to ask questions if that's so that will be right after this first topic, which is just kind of a general podiatry. All right. So let's our miscellaneous. So the first topic is just miscellaneous podiatry topics. This just for some did you think so? So just as some general background for you all, podiatry services have been defined by CMS as optional. However, OHP has felt that they are useful for our members and we should continue to cover them to some extent. Even if we decide not to put something in a covered code grouping, they would still be available for review for members under age 21 through the EPSDT process and for people 21 and older through the exceptions process. We are not going to be talking about ankle and foot fractures and other things that are currently on covered lines. For example, if you have like a great toe fracture, that's already on a covered line, so that will not be included in this review. And then any prescription drugs like anti-inflammatories or pain relievers that are commonly used for foot or ankle conditions are also kind of out of scope here. So the recommendations just in the general podiatry group is to create a code grouping for preventive foot care in high-risk patients, which would convert our current line 164 into a code grouping. It would include all of its diagnosis and treatment codes that are currently there. Then we would modify our current guideline, which is just basically the usual medically necessary instead of included on lines, etc. And then move the diagnosis and procedure codes from code group 482, which is currently a non-covered line. That's fractures of one or more phalanges, but not the great toe, up to the same, up to line 352, which should include everything except for the minor toes, and rename that code grouping just closed fracture of the extremities. Most treatments for these other types of things they're office based. We should be covering all the phalanges. I don't know why, and it's not really reflecting what's actually in 482. It's mainly just minor toe fractures, and that typically is just buddy taping in the office or other kind of low tech office procedures.
All toes matter.
All toes.
Does that include surgery? When it says, I see it says most treatment of lesser toe fractures office-based and low cost.
It would just be in all whatever the treatments are already in that code group.
For the grade.
I would have to look at what actually is in that. Look at
That's fine if you don't know now. I'm just curious.
Yeah, the ones that we're looking at would I can't tell you off the top of my head.
You're asking me if surgery procedure codes are on line 352 currently?
Yes.
Okay. I mean.
I would imagine they.
And just to note, most of the diagnoses will become evaluation and medical management. Ingrown toenails, we currently have uncovered and uncovered line without a guideline. So it would just be on the covered line, which is probably what's happening just since there's no restrictions.
Yeah, here are all of the procedure codes on line 352 as of right now, as of
Those are the
January.
diagnosed cases.
Okay, to diagnoses.
Yeah,
Wow.
it's an orthopedic line, so it's gonna have
Okay.
thousands of.
And open and closed fractures are both here or?
I guess 10 fingers, 10 toes.
Well, and then they divide up each phalanx of
Okay.
each toe.
And then you have left, right, and unspecified.
Then they don't have an ICD-10 for
and
final,
open
yeah.
and closed.
But this is,
Okay, now we're at CPTs, except that
is that all, is this all just foot?
this is through line 352.
You know, it's all of the extremity fractures.
Which specific code are you interested in?
I was just looking that up, yeah, I was trying to see if I
Yeah, here's the CPT.
Surgery
I'm not sure which one are the three.
code, see if we can get a little help from Google.
I've got the descriptions up here.
Got in the range of like 28400.
Can you go down just a little bit?
Sorry. What did you say?
284.
Like 28. Here's one, 285.
400 right there.
28515 would be open
Yep.
treatment of a fracture of a toe other than the great toe.
It's in there.
Okay.
Yeah,
So we're
that's
in there.
currently online 352, so yes, the answer.
Thank you.
Everyone,
Okay,
help me
so open-
welcome back
Open
Antoinette.
reduction is
Thank you.
definitely-
You're welcome.
Open reductions covered.
This is Chris. Can I ask a clarifying question for guideline note 232, high risk foot care?
Of course.
So I'm reading through it and I see that it's covered for the group A, complications due to systematic conditions that result from circulation and desensitization, or B, like skilled nursing, rehabilitation group homes. And then down below it says evaluation for tinea inguinum is got a separate group, the two above, and then also the very last group C. And I'm just wondering, does that mean that you don't get foot care if you are in the C group unless you have tinea inguinum? Or should that C group be included in the
No, we
accessible?
talked about this extensively a couple of years ago. And we previously had just covered people with systemic conditions like diabetes or peripheral neuropathies. We
Close
had
the
a
door, please.
podiatrist come to one of our listening sessions actually and talk about how these types of things can really affect your ability to like leave a nursing home. And that we didn't cover tinea inguinum, which is the sort of toenail infection, you know, the fungal toenail
Fungus,
infections.
yeah.
And we talked about how it, you know, it can cause lots of
Problem.
infections and things that it should be for high risk people. You should be able to treat it because it can reduce infections, ulcers, amputations, etc. But we limited that to you have to be high risk and you have to not be able to. So those are all ands for the
I see.
tinea inguinum. And then for the foot care, it's essentially just giving the skilled nursing facilities the ability to do foot care. And most of those people are probably going to be high risk by the earlier definition, but a lot of that foot care is done by nursing staff who can't make a diagnosis. So
Correct.
there was other reasons in there.
So I agree with the treatment plan for the fungus. I guess my question is, I'm thinking of a lot of clients with physical limitations that they can't reach their toes or do their own foot care
We
as
talked about
a
that
complication, but it's
extensively.
more of a
and-
physical. Yeah,
Yeah,
so
we talked about that very extensively and
not
a
as a
couple of years
cause
ago, and
of the
HERC
fungus.
didn't want to extend it because we couldn't define. It would be really difficult to define, like how much difficulty with ambulation, how much pain.
Yeah.
Those are sort of more subjective.
Okay.
And then it doesn't
That's
apply
good.
to somebody without fungal toenails, right?
Yeah.
So they just have, there's another code that we see a lot, L60.0, which is onychocryptosis, which is ingrown. So the nail might be not mycomic, but still be ingrown. But that apparently this only refers to B 35.1. They have to have that mycotic diagnosis from what I'm seeing here.
Yes.
Okay.
So
Any
there,
other-
so there's still folks who would benefit, but it's an optional coverage benefit. And so we're really just trying to target the folks that are most seriously impacted.
Yes,
Right.
correct.
Okay.
If it's okay with the chair and you all, I would recommend we do all the podiatry topics and vote on them as a group unless we run into a lot of,
Yeah.
real thick discussion on one of them and want to vote separately.
I agree with that.
Are you ready to move on to the bunion and hammer toe? So bunions and hammer toe.
Page 343.
Bunions are a deformity of the base of the great toe where the bones can kind of arc out. It can cause pain and it can cause trouble finding shoes to fit, etc. Hammer toes are where the toe itself has a contracture, also can cause pain, trouble walking, and trouble getting shoes. We talked about this at our May topic, or our May meeting. And we had a Cochrane review on the effectiveness of bunion surgery, which was found to have marginal clinical effectiveness and didn't change staff recommendation for coverage for people other than high-risk patients. So the recommendation at that time was for covering bunion and hammer toe surgery for high-risk patients, but that was part of the BUP. This was also one that kind of came back as, this is a really good idea, let's do this earlier. So most of what you see in your packet is the review that we discussed in May. And we are now adding a recommendation, because this is a somewhat more extensive coverage change. The recommendation is to have this effective 1/1/26, not 10/1/25. And it would add coverage for bunion and hammer toe surgery for people who have diabetes, peripheral neuropathy, or other condition that places them at high risk for foot complications, and a history of foot ulcer or infection stemming solely from the bunion or hammer toe, and they've had 6 months of conservative therapy, which is defined. And there's functional limitations such as ability to ambulate, care for self or family or employment, and they have adequate lower extremity perfusion and no evidence of degenerative changes of the MTP joint. And then the remainder of the recommendation for 1/1/27 remains as we talked about in May, essentially the same guideline note, but it would be attached to a new code grouping for preventive foot care. There is one change from the materials that you saw in May, and that was one of the tenotomy for the toe. I took it off of a covered line accidentally, so we would return it to 356. Actually, several of these codes would be the same. I'm sorry. So 28010 was identified by Dr. Superling as missing. So that would be added to what you saw in May, as well as left on line 356. A couple of other codes that were recommended for moving to the high-risk foot care would remain on 356 as well. These are all highlighted in your packet. They're just small changes from what you saw in May, other than the addition of the appropriate treatment code for hammer toe. Thank you, Dr. Superling.
Sure. That would, so that what was it,
28010.
28010 would pair in this new system with the B there, the hammer toe.
Yes.
Okay, okay, great, thank you.
Ariel, the change, the friendly amendment, is that something that you could email me so I can reflect it on here?
No, it's in the meeting materials. There's a change from what they wanted to approve in May. I just wanted to call it out for them so that they know there's a slight change in what they were wanting to approve.
And so there's nothing else that when I enter stuff in the database, I don't need it. Okay, that's.
Well, pending the discussion.
Yeah.
Any questions for me? And I know we have someone here to testify.
So that question, I'm just looking at, yeah, so big picture wise, as we move forward with the new system, if we happen to
Sorry,
miss.
Chris, I should back up
Oh,
one
sorry.
second. Could you just for the record introduce yourself?
Oh, yes, Dr. Chris Suffeling, podiatry, local private practice here in Portland.
Thank you.
Thank you.
Sorry.
Yeah, thanks for having me. So I was looking at some of the codes and things that could come up, like particularly with, because I think the intent of all this was to capture the high risk and diabetic people and preventing ulcers and infections, so bunion, hammer toes. But I was also looking at some other codes that we may have neglected, or maybe we will neglect, that could come up down the road, like Taylor's bunion, for example. I don't know if that's in there or not, but point being, how nimble and flexible will this system be moving forward if we say, oops, we forgot?
As nimble as it is currently.
Okay, so there is it's
Oh,
not
absolutely.
hard.
No.
Sorry, that's not covered on August 14th. We did not discuss that code, so it did not make the cut.
No, but it just has our usual lag. We only change our coverage twice a year, so if we
Gotcha.
learn this in October, it can't change until the next
Gotcha. Okay.
opportunity.
But there can be change, and there's still gonna be a prior auth type of system, like there is now.
That would depend on the CCO or fee for service Medicaid, what they choose to do.
Okay.
We
to be
don't decide on the prior auth. That's more of a administrative implementation.
Okay, gotcha.
And there's always an appeal process too.
Yeah, okay.
Chris, were there some that you identified?
Well, I think I had Taylor's bunion down, but I'm looking like it's M21.621, and looks like you're right on there in the C, so that bunion is not just.
I'm sorry,
additional bunion.
those, yes,
Yeah.
those are overarching generic terms. They don't include all the sub.
That's good, that's good. Yeah, I was just trying to think of any kind of prominence or ulcer
If
risk.
you do in the future, just send it to staff and
Okay.
we can look at it and make
Gotcha.
corrections if we need to.
Okay.
Okay, are you interested in giving testimony at this point?
Well, what gets me is that.
Can you please come up to the table just to make sure? everyone
Yeah.
can hear you?
So just so that our folks online and everyone can see you, if you don't mind having a seat at the table, right?
In the front, right here.
Fix it right here, so you can face everybody or however.
Yeah, and then what we normally do for public testimony is we have you say your name, any organization that you're representing, and if you're not representing anyone other than yourself, that's say that, and then any financial conflicts of interest you might have.
Okay.
And then we do limit testimony to 3 minutes.
Okay. My name is Lynette Jewell. I am representing myself because I have been shot down 3 times for surgery for bunions because I can't wear shoes. I can wear flip flops in the wintertime. It doesn't work. It is too painful to put shoes on. And it's like, it's not just the bump on the side of your toe. It's your freaking joint that is twisting around. So it's like trying to climb a ladder with a dislocated shoulder. That's what it feels like. I wish you'd explain more what it is.
What a bunion is?
Yeah.
Okay, I think
because,
that was a pretty good,
I can't wear shoes, I can't wear boots in the winter. I have rain-ons, which is a little dangerous right there as it is. And can't work, because who's gonna hire you if you can't wear shoes? Seriously. And it is. They say wear water shoes. No, that does not work. Anything that even just touches where the bunion is hurts really bad. It burns. And then the hammer toe thing is you're actually walking on the side of your toe and is pinching it down and pinching your toe to where it is causing your toe to get a big not callus, but just pinch, and the nerves hurt. And I mean, actually, It's like on this side. Actually, I shouldn't wear a skirt, but, and it's very, very, very painful. You can't walk very far because it starts to burn. I can't even have heavy blankets on my foot because it burns. And it's just, I had surgery on my ankle a few years ago and is messing up that surgery. That surgery is going to be non-valid shortly because I can't walk right. And it's like, why do the surgery on my ankle when it's just gonna get messed up anyway? Because I can't have the surgery for the minute. Because you can't walk right. I mean, seriously, you cannot walk right and it hurts. You can't just go out and buy a pair of shoes. No, never. Just flip-flops, which how good are flip-flops for your feet?
Good for job security for podiatrists.
Yeah, exactly. They're bad for your feet. I get cramps in my tops of my feet all the time from them, and I'm running out of time.
Are you Care Oregon plan?
Yes,
Plan, okay.
yes.
And you're not diabetic?
No, I have been, I have had, 2 surgeons send in referrals to have surgery 3 times and refused.
Ms. Joel, have you talked to the OHA ombuds team?
They said they won't talk to me. They won't. They just said no. They don't cover nothing. That's it. You don't get anything.
Yeah, but if we're using the current codes, yeah, it would be
So
denied.
after the meeting, staff can connect you with the ombuds team, which is a group at OHA that helps you
Yeah,
navigate, and we can.
Yes, there's nothing they can do. I already talked to them.
Oh.
That's who told me about this. And
Okay.
You've appealed and went through all the.
yes, for
So,
a few years now.
do you have any arthritis in that joint? Do you know?
Yes, now I do.
Now you do.
I have,
Well, you could.
I have
Yeah, we can't get into.
Oh, sorry.
Yeah,
we
This isn't the office?
No, we don't establish any patient relationships here, please.
yes,
So,
yes, I mean, I've got getting bone spurs and all that fun stuff. And it's just, it hurts. I mean, it is so painful, it's not funny. It's like I'm sorry, like castrating pigs with this rubber band around and it pinches and it hurts. And
Interesting.
it's just that my toenails are starting to get weirded out because they're like being stepped on all the time. And it's not exactly.
So Ms.
Okay.
Jewel, this is Daphne Peck. I do engagement for the commission. Can you hear me okay, Ms. Jewel?
Yes.
I have your email address. Is it all right if I reach out to you and see if I can help make a difference?
Yes, that'd be great.
Great. I'll do that next week. I'll be back in the office on Tuesday. So be prepared to hear from me, okay?
Okay.
All right, thank you.
thank you. Thank you for your testimony today. We appreciate it.
Any other discussion or questions? I forgot to note that we did get public comment on this in the early public comment period, and they advocated for coverage for average risk patients. So, not hearing any questions on this, I'm going to move on to plantar fasciitis. It's a painful condition on the bottom of the foot caused by inflammation of the tissue that connects the heel to the front of the foot. Treatments typically include icing and stretching, orthotics, NSAIDs, physical therapy, steroid injections, and surgery. You could also, people have tried extracorporeal shockwave therapy, platelet-rich plasma injection, low-level laser therapy, etc. Those are not standard of care. We talked about this in March. And And at that point, what Dr. Superling recommended further looking into steroid injections, splints, orthotics, and PT for plantar fasciitis. And orthotics will not be included. Orthotics are a separate issue, so we will not be looking at that for plantar fasciitis here. We'll be looking at the other treatment options. We looked at this in the orthotics we also discussed in May. And also I was asked to look at the steroid injections. We last reviewed this in 2019 and decided there was limited evidence to add coverage. So the updated evidence, so corticosteroid injections, there was a randomized clinical trial from 2023 of 182 patients that used either a heel cup of exercise or the steroid injection plus exercise. And they found that there was no clinically relevant between group differences after 12 weeks between the heel cup exercise or the corticosteroid injections. There was another RCT in 2023 looking at steroid injection versus ultrasound guided injection of dextrose, which is more about sugar kind of solution. They found that both decreased pain intensity and plantar fasciitis thickness clinically and statistically.
They're on page 380 of the packet. Sorry,
there's
Ariel.
a systematic review and meta-analysis on corticosteroid injections for plantar heel pain by Whitaker in 2019. It included 39 trials. One was considered low risk, the rest were high risk or unclear risk. They found moderate quality evidence that corticosteroid is similar to placebo for pain in the short and medium terms, and low quality that it was more effective than foot orthoses in the medium term, although there was low quality evidence that corticosteroid injections were similar to foot orthoses for non-medium term outcomes. And there was very low quality evidence that the steroid injections were similar to PT in the short and medium term, and very low quality for the long term. So it appears that corticosteroid injections is more effective than foot orthoses up to 6 weeks, but similar to PT. And also similar to placebo injection for both pain and function. And then expert guidelines, there's a clinical practice guideline from the American Orthopedic Physical Therapy Association. Obviously, being the PT Association, they spent a lot of time talking about the PT interventions. They also recommended that you should not use the foot orthoses. And then the American College of Foot and Ankle Surgeons recommend non-steroidal anti-inflammatories. Biomechanical support is safe and effective. That includes taping and wearing supportive shoes. They did find that corticosteroids were safe and effective, but this is an expert panel. And that they also found that amniotic tissue injections, platelet-rich plasma, Botox, and prolotherapy were safe and effective, but with an uncertain level of evidence. So essentially, recent systematic review and meta-analyses found moderate quality evidence that corticosteroids injections did not have significantly different outcomes for pain compared to placebo. 2 RCTs were identified that had been published after that systematic review, and they found no difference between corticosteroid injections and orthotics, exercise, or dextrose injections. Foot orthoses are found to be less effective than corticosteroid injections for pain in the short term. Physical therapy is found to be similar to corticosteroid injections in the short, medium, and long term, based on low or very low quality evidence. Another systematic review found poor evidence to support endoscopic plantar fascial release, which is a surgical procedure. Expert guidelines recommend stretching and wearing supportive shoes as primary treatment for plantar fasciitis. They're mixed on other treatments, including the corticosteroid injections. Based on the evidence of ineffectiveness, HERC staff does not recommend orthotics, physical therapy, corticosteroid injections, or surgery for the treatment of plantar fasciitis. Stretching, taping, and education on shoes can be done during an office visit. So the recommendation is plantar fasciitis should be in the medical evaluation and management group. The plantar fasciitis injection code should be removed from the neurologic dysfunction line. And then we would delete that the plantar fascia injection, that we have a current guideline for a non-covered line that states that that code is used for corticosteroid injections only, which we wouldn't need because we would not be covering it. Questions about any of the plantar fascia issues? Plantar neuromas. Moving on to plantar neuromas, these are nerves that get pinched between the bones of the mid forefoot, and they can cause pain and trouble walking, numbness, and other symptoms. Treatments generally wearing wider, more supportive shoes, custom orthotics, non-steroidal anti-inflammatories, cortisone injections, and in cases that don't respond to the conservative therapy, surgery. We discussed this also at our May meeting. There was no substantive discussion, but just as a reminder, we hadn't had the appropriate public notice of these, so they all had to go out for public comment. We did receive one public comment on this, which recommended adding corticosteroid injections for plantar neuromas. And they submitted 3 articles, one of which has been added to the evidence review. So there is a 2024 review, a systematic review of Morton's neuroma, which is one specific type of forefoot neuroma. There were 6 RTCs and 6 longitudinal observational trials. For corticosteroid injections, there were 5 RCTs, and the use of steroids decreased pain on average of 52% compared to an average of 33% in control groups. And they also looked at various other types of injection. The authors concluded that corticosteroid injections were effective in reducing pain associated with Morton's neuroma and had a low risk of complications. However, staff, when we looked at the included RCTs, only 2 of them had a control group and an outcome of interest. Those 2 specific RCTs did not show a clinically important difference in pain reduction with the corticosteroid injection. There was another systematic review published in 2021 by Liu and colleagues that had 35 studies with 39 cohorts with about 3,000 patients. They looked at neurectomy, which is the surgery, and they found that it was effective 74% of the time for complete pain relief and 18% of the time for partial pain relief, and 6% there was no pain relief based on 12 cohort studies. There were complications, the most commonly reported being wound infection, as well as hypertrophic scarring. And they conclude that the Morton's neuroma can be treated by injection, neurectomy, and neurolysis. And they noted that the current surgical literature shows a trend toward greater complete pain relief. And then there was another systematic review and meta-analysis of 2019 of 22 studies. They looked at things with like extracorporeal shockwave therapy that we don't cover. And their look at corticosteroid injections included 7 studies. And they found a VAS 100-point scale pain relief of was minus 5 points when the minimally clinically important difference would be 20 to 30 points for that. And then there was a Cochrane review of interventions in 2024 that you've previously seen that found insufficient evidence for all treatments. The American Academy of Orthopedic Surgeons recommends wider footwear, foot orthotics, and corticosteroid injections. And they did recommend surgical treatment, with noting that the success rate is 80 to 95%. Looking at private payer, Blue Cross and Aetna cover orthotics, corticosteroid injections, and sclerotherapy. So in summary, based on 2 high-quality systematic reviews, there's low quality or no evidence that corticosteroid injections have a clinically meaningful impact on pain. The one study did show a statistically significant benefit. Sclerosing injections and padding and orthotics have evidence of no effectiveness. One additional systematic review was submitted by commenters, and review looking at the included studies. The 2 studies that had controls didn't find a clinically important difference in outcomes. Expert guidelines recommend wider footwear, shoe inserts, and corticosteroid injections. One lower quality systematic review was included as it examined neurectomy based on cohort studies, and it found a high percentage of patients reported pain relief with that procedure, with the major adverse event being wound infection. So HERC staff recommends consider continuing to basically current care, which is lack of coverage that would place plantar neuromas in the evaluation and medical management group, and the excision code for excising Mortensen would be the not medically necessary file. Any questions, input there? If not, we can move on to orthotics. This again was discussed in May, but needed to be put up for formal public comment. We did not receive any public comment. So staff have not changed the current evidence review or the current staff recommendations, as we had no public comment. So we are continuing to recommend that we leave orthotics in the preventive foot care grouping, and then but use it for non-custom made orthotics, and our hallux rigidus guideline would have wording changed to reflect that it's non-custom made orthotics. And then our hallux rigidus would have the same change. And there were a couple options discussed in May, but this group overwhelmingly wanted to cover the orthoses for high-risk feet.
And I'm sorry, Ariel, just my clarity, your staff recommendation is that adding that range of CPT codes is that's effective 10, that's effective 1/1/27. The guideline note change is effective now, or all of it's effective 10/1?
It would be effective 10/1.
The codes too.
Yes.
Yeah, it's all of them.
And the only changes for 27 would be just the wording changes that
all of this is effective
10/1/25.
And what is this new?
We would be adding the physician provider code for the orthotic management to the high risk foot line for prevention of recurrence of foot ulcers that were caused by high risk foot conditions.
So not the orthotics and 3,000.
The orthotics.
Wait, it doesn't. Yeah, and there's rules, so there's things like if it's part of a foot brace and all of those aren't changing. Those would be continued as they are already outlined in rules.
In OERs that come from CMS, and
I think they would look at removing the requirement that the patient have diabetes specifically.
Yeah.
To obtain what?
So, yeah, right now, only diabetics can have orthotics, so what would actually happen with this is it would be diabetics and other people with high risk feet, so people with neuropathy and not due to diabetes, severe peripheral vascular disease. It would expand coverage to a slightly bigger pool.
But more for those high risk ulcer issues, not
Yes.
like plantar fasciitis.
Right,
neuroma,
just for high risk
things like
ulcers.
that.
Yeah.
That's
And-
what,
For this,
PAD, things like that. Okay.
And we can approve this all 10/1/25, but just as a note, because this would require a rule change, it may not actually be implementable until a somewhat later date when the OAR can be modified to take out diabetes and put in, high risk types of feet.
But that code L 3000 is
outside of our control.
included there.
Those L codes are not part of our decision for today.
Yeah.
They'll have to cover the appropriate devices to.
So what are those codes there? I don't know.
Those are the physician, podiatrist, for other provider PAs. The office time to, I don't know.
Those aren't
Their
E&M
management
codes, though, right?
training.
Those aren't E&M codes, like
No, they're
99.
CPT codes.
I mean, 99213, that's not office visit.
They're not office visit
No.
codes, they're orthotics management codes.
Orthotics management training.
So you have to meet whatever the coding manual says for those codes.
Yeah, you may have to be the technician. I don't
Yeah, I
know.
don't know. I've been managing orthotics for 20 years. I don't know what's.
It may not be, actually, I may have misspoken. It may not be a physician code. It may be a technician code. I don't know.
You just jot that down, it's great. Okay.
Other thoughts, questions, concerns?
Is that everything we had to say about podiatry?
That is it.
Okay, so I do have something to say, if now's the time.
Okay, again, if you give a full introduction of who
I'm
you
sorry,
are.
Dr. Chris Stufeling.
Yes,
Stu
thank you.
Podiatry.
And we have a 3-minute timer that we're giving.
So, thank you. I just wanted to say, how we got here today, we talked today with Dr. Smith's talking about neuroma, bunions, hamatoes, plantar fasciitis, all that is fine. Certainly, there's other podiatry conditions that are out there. We sent out, after the May meeting, we sent out a group to our fellow podiatrists email saying, look, we're not gonna get all these covered, but drill down your top 5 or whatever conditions that you'd like to see covered. And of course, this is talking about elective things. This is not talking about the high risk population. First, I want to step back, applaud you guys for stepping up to realize the importance of that and covering that moving forward. That's a major breakthrough for that patient demographic. So good on that. We hope to move forward to get things covered for elective for all patients, such as Miss, I forget your name, but her situation I hear all too often with painful bunions and other issues. 22 other states are covered for all podiatric issues on Medicaid. Of course, that gets into finances, budgeting and all that. We hope to get like one of those states eventually. So, but in the meantime, we are failing as a profession, not in our treatment, but I think in our research. Because we went all through all that. I do these treatments every day, just did a cortisone injection for plantar fasciitis on a Garo organ patient yesterday as a courtesy, knowing I wouldn't get paid for it. So I'm just gonna eat that, but I know it helps. You know, if you take that away, what is she gonna say? What am I gonna treat her with, new shoes? It's not gonna work. So we need to do better as a profession. I talked to our mothership. We need to get better research out there so that my data, I was hoping would trump your data. It didn't. So, which is unfortunate. I thought there'd be more data out there, but until there is, we are stuck in this situation where a lot of these treatments that we know are effective for elective issues are not going to be covered. So it's a thank you, and it's we need to hopefully improve moving forward. So.
And I tried to summarize, so the Podiatry Association submitted a very nice public testimony. I tried to kind of highlight the various topics. We kind of separated it out into that, but and it was you had all the PCDs and
And when I say no data, there's different levels of data,
Yeah.
right? It's not the level 1 that you're looking for. There's lots of lower level anecdotal data. Shockwave is one that's really coming out. A lot of the studies are done on rabbits from the 90s. Now there's a lot of new studies coming out that hopefully will support that, but you know, at least it's a moving issue that we can improve on moving forward as data is revealed.
And podiatry is not alone, a lot of surgery.
Yeah, it's not just a podiatry thing.
Yeah, so great, thank you.
Is that 3 minutes?
It is.
And thank you again for all of your input and the Podiatry Association.
Thank you.
Yes, absolutely.
This is
All
Chris.
right. Yeah, go ahead, Chris.
I want to thank you, Dr. Suferling, for your time and all the effort you put into it. It's very clear that you're passionate about this topic. I was also looking at the difference between the expert guideline recommendations and kind of where you're coming from with the data. And so I appreciate that, you know, the recognition, but also, you know, the call to action to try to get that data to support it in a format where we can move forward with it. We want to do that too. Thank you.
Thank you.
All right, if there's no further discussion or questions, we can vote on the podiatry topics. I don't believe there were any modifications.
I don't think so. So I think it's all kind of a package deal, in the agenda there, A through E. Entertain a motion of any kind.
Motion to approve.
Staff recommendations as
Staff
written.
recommendations.
Great, thank you, Adrian.
This is Chris, I'll second.
Oh, I'm sorry, I misspoke earlier with the hammer toe codes. Those actually weren't in your packet. Those were things that were as a late addition, so that is as modified with a friendly staff modification.
Updated to as modified.
Correction as modified. Well, you still.
Second as modified.
Chris, thank you. Okay, roll call.
Thank you. Antoinette,
I approve with a motion.
thank you. Mary,
Approve.
Adrian,
Approve.
Lucy,
Cut everybody else loose.
Approve.
Sarah,
Approve.
Chris,
Approve.
Holly Jo.
Approve.
Thank you. Motion passes.
All right, thank you all. Those of you that are here for podiatry, you're released to your usual selves,
All right.
as you wish. Thank you for coming.
Thank you.
And so for the rest of you, we are going to jump back to section 6 of the benefit update project and pick up the last 3 ENT spots. And then those of you online will be free to go. And those in the room will get to eat lunch and go. So bonus for coming as you get lunch. All right.
Our next topic is tympanic membrane perforation. These are holes in the eardrum, also known as ruptured eardrum. It can be
Page
caused by
317.
like Q-tips, which I hate. It can be caused by infection or sudden changes in pressure, like in scuba diving. Generally, these heal on their own, and you just need to observe. The majority will heal in a few weeks. You may need antibiotic drops if it's caused by an inner ear infection, but in rare cases, you need to repair the eardrum. Currently, the perforated tympanic membrane repair codes appear on the hearing loss lines as well as a non-covered line. And this is part of our sort of workaround. Then a lot of our ENT stuff that was close to the funding line is under the funding line, and we wanted to cover if it's hearing loss. Consulting with our ENT experts, they recommended repair of perforated tympanic membranes that don't respond to initial observation when they cause hearing loss or when they're associated with recurrent otitis media. And they note that lack of repair can cause complications down the line, and it can be cost effective to repair. So the recommendation is to create a new code grouping called tympanic membrane perforation, adding the ICD-10 and CPT codes in the table below, which are the perforation diagnoses and treatments, and all the medical evaluation codes. And then it would have the current guideline for eardrum repair would have the usual, basically, medically necessary instead of included on the line. There would be one substantive change, which would be currently be covered if there is documented hearing loss for more than 3 months. And we would add the other indication, which is recurrent inner ear infections associated with the perforation, based on our expert input. Questions, concerns? And then the next topic is the medical director's favorite topic, which is tonsillectomy. So this, at least for fee-for-service, is a lot of exceptions come.
Page 334.
So in your packet, there was the treatment of sleep apnea, which you have extensively edited. So that was in there just basically for your knowledge. Basically, what the staff recommendation is to create a single code grouping for all indications for tonsillectomy except sleep apnea. mainly because we have spent so much time on the sleep apnea guideline and it's specific. But we would recommend a single guideline for infections and all the other things. And then we would attach a guideline that is essentially the current guideline with just the appropriate wording changes. Questions, issues with that? The one indication peritonsillar abscess would stay on the peritonsillar abscess line. Okay. Last would be miscellaneous ENT issues. So we have multiple ENT lines.
Page 340.
Essentially, the staff recommendation would be, we currently don't cover something called cauliflower ear, which is where the outer ear, a lot of wrestlers or other people get with trauma. They can have blood collections and it can cause complications. Based on expert input, the recommendation is to add coverage for drainage of that blood collection to prevent the downstream complications. And then adding a couple of other inner ear diagnoses that our experts have told us can affect hearing. And then otherwise, most other things that are currently in the non-covered region would continue to be covered for evaluation and medical management only. And then we would do just our typical guideline note wording changes for guidelines regarding the microodia or the external, really small or missing external ears, sclerotherapy of fluid injections, frenulectomy, frenotomy, and benign paroxysmal vertigo. Just as a quick update to you all, there'll probably be future changes with the tongue tie guidelines, and we would continue to update that as appropriate. That's another common complaint. So essentially, this is keeping current practice. There are more extensive changes for frenotomy of tongue tie. And it is, so right now, we have a very extensive frenotomy guideline that kind of points you to where all these other codes are covered. I don't know why, I guess we're saying it's medically, so we're taking it kind of all out of, we're just basically saying when it's medically necessary and when it's not, rather than pointing to which code group and which line it's in. We're saying it's like medically necessary only for cancer treatment.
Got it. The one code.
81115.
The Z plastic.
And 41010 and 41115, which are the more extensive, under the tongue, big procedures.
Z plastic.
They're medically necessary for cancer treatment.
Only. Got it. Okay, can I go back? Just one quick question here on the repair or defective tear of eardrum. So the tympanoplasties. So does this mean that, as I look at this on page 333, that these would be covered with the 69620 would cover even without hearing loss, right? So
it would have to have, because of the guideline, it would have to have hearing loss or recurrent inner ear infections.
So what we see requested is in kids where they're removing tubes, like one fell out, they don't need them anymore, one's stuck, they remove a tube, they want to fix the hole. Technically, the way it's written now, if they don't currently have hearing loss, the tympanoplasty is not covered, correct?
So we could, if you want to do that, we could say hearing loss or infection, or if repaired during other ear,
or at the same time as tube removal.
So, or if
I mean, I think the
repair
theory is that, you know, technically they should close up on their own, but oftentimes if this is not the first set of tubes, you know, it's scarred, they don't close. And then you've got a kid with a hole in their ear.
So I have additional wording. So it would say the hearing loss that we currently have or recurrent inner ear infections associated with perforation or when done in conjunction with PE tube removal.
hers was easier to read.
No.
But yeah, this gets the plain language word.
Exactly. Conjunction, come on.
Is that?
Yes, with, especially with the perforation or during ear tube removal. I like it.
Just doing during ear tube removal.
Yeah, okay. Plain.
And I know
nobody has
that
to
that's
look
been
up
an exception
conjunction.
for, that actually will be an improvement. We just reviewed a case yesterday about that.
I hear you. So did we, that's, they were
We're not
just like,
putting this poor kid under anesthesia twice.
right. My staff says, thank you so much. It's a very common thing. What else does I have? Other questions, thoughts, concerns?
Actually-
Antoinette, thank you. Good to see you.
So I know this is simpler wording, but it may not, just my English major mother, like, it's medically necessary when there's documented hearing loss or recurrent inner ear infection or
During,
when done during ear tube removal
or during ear tube removal procedures.
I see what you're saying.
Or when performed during ear tube.
I think we should do just a,
Verb there.
yeah, we need another
We need
verb. Or when performed during ear tube removal.
Okay. All right. Wordsmith to death. And all those other things are defined elsewhere. Is that, so documented connective, so hearing loss greater than, okay, got it. And or recurrent ear infections associated with perforation. Recurrent, do we have recurrent defined somewhere?
No, this is the entire guideline.
That's it. Okay, we have some problems.
What would you like for recurrent?
Whatever are you trying to mimic our acute or chronic? It should be the same as either our acute or chronic or both. Ear surgery definitions.
Yeah, we have
More than 2 inner ear infections in a year, I don't know.
I think it's more like 5. It's a lot.
Oh, well.
Yeah.
So like recurrent means 2. Is that really what we mean? Because that's not.
Hold on, I'm pulling up the PE tube.
Because to get the tube in.
3 or more well-documented and separate episodes of acute otitis media in 6 months, or 4 or more well-documented and separate episodes in 12 months, with at least 1 episode in the past 6 months.
Or 3 a year for 3 years, or.
You just want to do 3 or more?
I'm good with 3 or more. Everybody good with 3 or more, Mary? Recurrent equals 3 or more
In a year.
in a year? But we just gotta define it, or are we
So
all
recurrent can
defining
be
it?
parentheses, 3 or more in 1 year, inner ear infections.
3 or more in 1
Oh,
year.
you wanted it kind of parenthetically, okay. Or recurrent, parentheses, 3 or more.
Recurrent, parentheses, 3 or more in 1 year. Ear infections associated with perforation. Okay, I'm happy there. Okay, so you defined documented conductive hearing loss greater than or equal to 25 dB, persistent for more than 3 months. And is that? I guess it would just be in that ear. Because we're only talking about doing eardrum repairs in an impacted ear, so, okay. Or recurrent, 3 or more, associated with perforation or when performed during ear tube removal. Okay. You know, I like it. Okay. Anybody else with an English major?
I don't have an English major. My mother was an English teacher.
There we go. That could be worse.
And he, I think, he had a,
I had an English major.
yes.
but I think it's good. It's clear. It may not be perfect.
Yes, but no, I like clear. We like clear and
It's not Shakespeare,
exactly.
thankfully.
So we'll take those last number items 2, 3, and 4 in mass. If somebody would like to make a motion.
Hi, it's Mary. I move to approve.
Lucy, second.
Yeah, we need, Mary, we just need the staff recommendations as modified.
For the staff, yeah, sorry, for the staff recommendations as modified. Thank you.
Perfect. My second was
Lucy.
Lucy, thank you. Still second? Yes, great. Let's roll call. Thank you.
Antoinette,
I approve the motion.
Mary,
Approve.
thank you. Adrian,
Approve.
Lucy,
Approve.
Sarah,
Approve.
Chris,
Approve.
Holly Joe Hodges.
Gladly approve.
Motion passes. Thank you so much. Great meeting.
Yay, you guys are early.
All right.
Eat without talking.
Before we adjourn though, I want to correct something I said during the staff report.
Yeah, we got a couple more things.
Oh, we do have? Okay.
Well, no, go ahead.
So for coverage guidances,
EBG was going to
the sleep apnea surgery will come to EBGS in September, so that should be coming to you around the beginning of the year for the guideline note. Published as planned. Then we will be starting a new coverage guidance, which will be going out for scoping in the next couple months on omnipods, which I know are in increased demand.
They are a form of an insulin pump that's disposable.
Okay. All right.
It'll go out for comment on Monday, so watch for that. Thank you.
This Monday
This coming Monday
for,
Or 7 days
for
for
omnipods.
the scope.
okay, great.
And
Okay.
that'll scope the coverage guidance.
For EGBS.
And then it'll be February before we can actually.
Okay.
Yeah, report.
And then public comment, I think we just need to make that a public statement that we're available for public comment. If there's anybody online, there's nobody here in the room.
Yeah, nobody registered.
Nobody registered. Okay,
Do you want to
great.
talk about the ABA plan?
That'll probably be coming in January or thereabouts. And that was a request made by a legislator for reviewing applied behavior analysis for people with intellectual disabilities. And so we've done some evidence and some contextual review, and so we'll bring that all together for you all.
But not the changes. Okay, so let's talk about next meeting. So the next meeting is October 9th. Anybody know they won't be here? I won't be. And it says online, does that mean online only or
Online
and okay, and in
We'll
person?
poll again, but.
Yeah. Okay, and then December, can we just say, did you just say it's canceled?
No, we have a October, you all will meet in October and in November. The EBGS meeting that was planned for December is tentatively canceled.
Oh. Dang,
I'll be absent in October.
sorry.
Thank you, Lucy. Lucy's gonna be absent.
Okay, and so we have to meet again in November. For some reason, I thought we were free until January.
No, you have all those CPT codes.
Oh, how fun.
Always CPT codes.
CPT
End of the
codes.
year.
Nice try that.
I know, nice trying. So November and then January. Okay. All right. Any other thoughts, questions? Fabulous to see you all. I like this format. This tech is much better. This is great. I hope that worked better for you all. I love being able to see your faces. I can see your furrowed brows. I can see when you want to say something and haven't raised
Did
your
you
hand.
see what I was eating?
No, I didn't.
Delicious.
I didn't. That was good though. All right. So you have any
The
suggestions,
real
questions?
test will be if I can hear Max. Real test.
You are very demanding.
Yeah.
Yes,
Well.
I am.
We'll get him to project. All right. Well, thank you all very much. Have a fabulous rest of your summer, and thank you all again. We can call this adjourned.
Thank you.
Good to
I'm
see
gonna
you.
hold,
See you later.
Bye-bye.
I'm gonna hold this meeting open and put up a little sign that says we're on break. If you want to stay in this room,
Thanks, Daphne.
betcha.
I can do that.
Oh, thanks, Michelle. Appreciate you.
Till
1:30.
Oh,
So we actually get a break. A break.
1:30.
Thanks, Michelle.
Sure. I'm in a since it's well, we don't start again until 1:30. I'm gonna go run an errand and I'll be right back.
That sounds great.
It
Oh, and I'm
won't
gonna
take
stop
very long.
recording.